Thanks for having me here. I'm always impressed with what Needham is doing and the attention that they pay to behavioral health. And it's a very generous gift that's going to make a big difference. I have a few slides today. I'll just go to the next slide. I was asked to talk about the behavioral health initiatives and now and looking ahead. So I'll just go through very quickly the three initiatives that were in the assurance of discontinuance with the Attorney General. And I want to say, we always call these the Attorney General initiatives, but these are really our initiatives. These initiatives are very mission complementary, and we're very happy to be spearheading them. I can go to the next slide, please. And the first one, and next slide, is collaborative care. And what that is embedding behavioral health clinicians in primary care practices to increase access to mental health services. So generally the people who are receiving these services are people with mild to moderate depression, anxiety, substance use disorders, et cetera. It's not really aimed at a person with a major mental illness who needs specialty care, but it absolutely increases the access to behavioral health care. It integrates it into primary care, which is where it should be, and it takes a lot of the stigma of receiving mental health care or addiction treatment away as well, I think. So the requirement was that 50% of our employed practices had embedded clinicians, and these aren't just putting a clinician in a practice. There's a patient registry, there's very specific outcome measures. Does it matter that we're doing this? Are people getting better? How long does it take them to get better? And there's a particular evidence-based model that several evidence-based models that these clinicians are using. So it's a much bigger process than let's add a social worker to one of these primary care practices. So we were supposed to embed 50% of the employed care sites in 3 years. We actually are ahead of that because this is, let me see, March. God, we're moving into the 3rd year, I guess, but time flies. Or maybe the 2nd. Anyways, we've exceeded this because we have 40 integrated sites right now out of, that's about half. 40.5 actually is half. So we're going to take the credit. You can go to the next slide, please. I'm not going to go through this slide. I put this in case people wanted to see it, but these are all the practices in the system, employed practices. And if you could go to the next slide, it has Needham specific practices or places that are near Needham. So the employed practices, these are all primary care practices employed by BILH. And so these practices, some of them have already begun. Some of them you can see that are closer to Needham have 2021, and some of them are pushed out to 2022 and 2023. We embed about 15 practices a year. It's really a pretty big undertaking to embed and onboard that many practices in a year. So you can go to the next slide, and you can go again. The Centralized Bed Management was the agreement with the Attorney General that we centralize the 14 programs within BILH that provide either addiction or inpatient psychiatric services. And that we have a way that we really ensure that those beds are fully utilized. Unfortunately, and you'll hear more about this from Dr. Mendoza, I'm sure, there's no problem making sure that these beds are fully utilized. The real problem that we have related to COVID is the perfect storm of increased need for services, particularly in the pediatric area and geriatric, but pediatric people are showing up in the ED in much larger numbers than they have previously, secondary to COVID, kids not being in school, prevention services, et cetera, not necessarily being that available, and community services, like outpatient services generally, having less capacity than they had pre-COVID. On top of that, we see an underbedded system that has even less beds than it used to have, whether we're talking about shelter beds or we're talking about beds for inpatient psychiatric or inpatient addiction units, because people have made the changes required to be able to care safely for people in a COVID environment, which meant that several hundred beds have come offline. So you have this increased need, this decreased access related to beds, and it's even harder. The downstream impact of that is also very difficult because you see less capacity in the outpatient and ambulatory system as well, which is one of the ways that people can be safely discharged from these facilities. So I'm sure Dr. Mendoza is going to talk more about it. But we have established a daily huddle, we call it a huddle, between all the emergency departments and the inpatient psychiatric and addiction programs to ensure that our beds are fully utilized. More importantly, what we're really focusing on is there's a BILH, Behavioral Task Force, which involves people from across the system, including Dr. Mendoza, where we're really trying to figure out how to deliver care more quickly to people in the EDs, especially psychiatric care, successfully transition them to inpatient bedded programs because of everything I just talked about. We can go to the next thing. So, and you can go to the next one. So medication assisted treatment, for people who may not know, is it's called MAT, medication assisted treatment, is for people who have opioid use disorders. There are 3 medications that are approved by the FDA. And the requirement here was that we basically enhance access to medication assisted treatment. The opioid crisis has sort of lost some of its visibility related to the pandemic, as has everything else. But for the first time, the state reported a slight increase in opioid overdose deaths. So this is still a very important initiative. And so we have 3 clinics, and I'll show you in the next slide what a bridge clinic is, at BIDMC, Mount Auburn Hospital, and Addison Gilbert. We have what you call same-day admissions. Come in, it's treatment on demand. Come in, you need medication-assisted treatment. We can do that for you in the 2 opioid treatment programs that are methadone programs. There's also Suboxone in this system and Vivitrol. We were lucky to partner with Boston Medical Center, who received, I think it's an $89 million grant from NIDA to increase access to medication-assisted treatment in certain communities that are more hard hit, Gloucester being one of those. And we also have the ability to do induction, meaning to give people who are interested, who present in the ED with opioid use disorders, sometimes overdose, sometimes they just have an opioid use disorder and they're there for another reason. We have the ability to induct them, to begin them on a medication, one of these medications, usually Suboxone or buprenorphine, better known as Suboxone, and then send them immediately to the bridge clinic. Next slide. And so that sort of explains what a bridge clinic is. You know, it's if you get medication in the ED that you need to continue, you can go to one of these clinics and have that continued until we can put you in a more permanent situation in the community. And it's important for the reasons we just talked about. Opioid overdose, unfortunately, is alive and well. Fatal opioid overdose. It is a public health crisis that continues, and medication-assisted treatment is the most effective treatment to prevent opioid use deaths. So That's why we're doing that. And then I think we're going to the next slide, which is trying to get it all done in my time frame. What's ahead? And we can go to the next slide. So clearly the expansion of telehealth is one of the lessons learned from the COVID pandemic. One of the lessons that we have learned, which I see some familiar faces on this call, which I talked about some, is that there is very significant health disparities in telehealth. So we can see ourselves that the uptake in telehealth is very different in a clinic that we run in Lawrence than a clinic that we run in Beverly or some of our other clinics. So there are real social determinants of health that are affecting the use of telehealth and have the possibility of expanding health disparities instead of closing them. And so we really are paying a lot of attention to how do we do that, and how do we ensure that we service those people who either are not appropriate for because their mental illness is too significant, or just simply cannot access telehealth. And then, Dr. Mendoza, I think, is going to talk about some of the strategies to address the psychiatric treatment of patients in the ED, but that is a huge problem across the state and certainly in our EDs. And he'll talk about some specific reasons why it's worse in the Milton and Needham EDs. And then we, as a system, have very much committed to diversity, equity, and inclusion work. And there is a huge amount of work to do in the behavioral service realm, like everywhere else, if we're really seriously going to address those issues, which I feel confident the system is well poised to do. So that's it for me. Thank you.
Thank you so much. Thank you so much, Hillary.
Questions last, I think.
Yeah, I think we're just because we have quite a bit to get through, Hillary. I think I have a couple of questions. I'm sure other people do, but I really appreciate you giving us that overview from your perspective. And I learn something new every time I hear you speak. So, but I think we are going to ask Dr. Danny Mendoza to step to the podium, if you will, and then we'll go from there.
Thank you, Sam. Can everyone see my screen?
Mm-hmm.
Is that a yes? Okay,
Yeah.
great. Thanks. So I'm Danny Mendoza. If you notice, my initial slide is about behavioral health needs at BI Needham and community. And community underscores, I think, one of the most important lessons that we learned from working with the Health Policy Commission. In 2014, I applied for a Health Policy Commission grant for Chart 1, where we were able to embed behavioral health clinicians, a social worker, and a part-time psychiatrist in one of the primary care practices in Plymouth. And that was a great success, followed by a much bigger grant to embed psychiatrists, psych NPs, and social workers in 5 practice sites in Plymouth. So one of the things that I wanted to emphasize from our experience is that I wanted to make sure that people understood that it wasn't just the hospital that was doing the work, that the grant was also meant to develop and enhance relationships with freestanding psychiatric clinics and hospitals in the community, enhance our relationship with the drug courts, with the school system, and the freestanding agencies in the community, like the federally supported clinics that took care of the underinsured. So I will go down the list as I try to give you a kind of like a history and as well as a current state. So I was lucky enough to spend all my career in Boston. I trained in Boston, and I left Longwood And as one of my mentors used to say, if you want to earn a little more, just cross 128. And since my wife said that we couldn't pay our mortgage with prestige, I decided to listen to my wife. Um, but historically, the Southeast region has always struggled with inpatient behavioral health capacity. And despite the fact that Stewart, with its multiple hospitals, um, had 350 more or less inpatient beds, and the Arbor system having probably around the same, the Arbor system has lost a lot of beds, including um, its beds at um, Westwood. And that had a significant impact on Milton and Needham. Now, towards the earlier part of the pandemic, there was this incredible lull, similar to what happens when a tsunami hits. It seems like everything is quiet and the waters have receded far beyond the shore. Um, Everyone of us in the behavioral health field felt that the wave was going to come in eventually, but um, people were lulled into submission. And even with Norwood's closure, I think at the end of June, we didn't feel the immediate impact of the wave. But right now, we're feeling the full impact, particularly since Norwood had 60 inpatient psychiatric beds, including 28 geri psychiatry beds, as well as an ECT service. In addition to that, they had a very busy emergency department that did behavioral health evaluations, and our ESP Riverside went to Norwood. So, what we're seeing, and I'm seeing this because I am it for now for psychiatry for Needham, um, we have seen the migration of the Norwood patients to the BID Needham campus, both in the ED and the emergency department. And I think our case management department, our nurses, our ED physicians, ED nurses are working heroically, but this is not the type of patient that they're used to taking care of. When I started working with John Fogarty and Greg McSweeney a few years ago, we were focused on taking care of the Jerry psych patient because Needham is surrounded by a lot of nursing homes. So we not only have that patient population, but we have this new patient population from Norwood. Now, the challenge here is that Stewart is prioritizing the admission of behavioral health patients from their own emergency departments. Now, Faulkner Hospital is another hospital that's relatively close by, but they tend to take from within the Brigham ED and the Faulkner ED. The medical center DEEC-4 inpatient unit suffered from a closure and a decrease in its capacity because of COVID-19 infections within the unit. Newton Wellesley also has been much more difficult to get patients into. And I already mentioned the Westwood closure as part of the Arbor system. In terms of geriatric psychiatry, McLean is a terrific geri psych unit. I did part of my residency at McLean, but the McLean geri psych unit does not take anything remotely medical. In other words, if a patient has an IV or needs oxygen, McLean cannot take care of the patient. BID Plymouth and Mount Auburn are the only Department of Mental Health licensed geri neuropsych units within the system. So a quick survey of current state. BID Needham has consultation liaison, which is general hospital psychiatry via telemedicine. That's all we have right now. Again, we have a terrific case management department. I'm constantly amazed at the level of responsibility and ownership of our case managers. This is not necessarily the case in community hospitals. BID Milton, Pete Healy had asked me to start a CL service at Milton probably about 5 years ago. So we have a full-time CL psychiatrist at Milton. And we have, I think we have just one FTE of social work working within the Department of Case Management. Again, their case managers are terrific to work with, and I run on their patients. They have recovery navigators through Gosnold, and I'll talk about recovery navigators later on in this uh, in my spiel. Now, BID Plymouth has one FTE CL psychiatry split among several psychiatrists. We have a 19-bed Jerry neuropsych unit, and we have holiday weekend coverage by inpatient psychiatry. And we have a big social work department, which for me was one of the best things that ever happened in Plymouth, um, because as part of the Health Policy Commission award, we were able to figure out that um, the patients that were the most expensive in the system to manage, the patients that tended to be readmitted or be sent back to the ED, are patients with psychosocial issues. And case management, at least in Plymouth, was ill-equipped to deal with them. And then we've had this long-standing relationship with recovery navigators through Gosnold. Now, being more specific to the emergency department at Needham, we have the emergency service provider, which is Riverside. Sorry, that was actually Riverside's supervisor calling me about a stuck patient. Um, we have CL psychiatry Monday to Friday via telemedicine, office hours. And again, that's just me at this point. Uh, Greg and John and I have been trying to hire a CL psychiatrist at Needham, I think for the last 2.5 years. And before that, they were trying to hire somebody through Bill Greenberg at the medical center, but it's been very difficult to find CL psychiatrists. At Milton, we have Aspire as the emergency service provider. And we have CL psychiatry Monday to Friday for complicated cases in the ED. In Plymouth, we have this interesting mix of providers. The underinsured, which is Mass Health, Free Care, the managed mass health products are seen by the ESP, which is Child and Family. Commercial insurance are seen by McLean for level of care assessments. And then my BID Plymouth ED behavioral team that I started through the support of the Health Policy Commission grant does the treatment and potentially the placement for a lot of these patients. Now, you're probably wondering why 3. Well, it's something that I inherited, and it's something that I'm trying to work on and consolidate. It hasn't been easy. When we lost the funding with the Health Policy Commission in 2017, I had to lay off a lot of clinicians, social workers, and nurse practitioners. And now that we have this crisis, and as Hillary alluded to, this issue of managing people in the ED, I wish I still had them. But in any event, in Plymouth, we have a daily huddle at 8:30 every morning, where the ED chairman, myself, the psychiatric NP on Monday and Friday, the social worker, the ER nurse manager, and the ER social workers meet every day to go over all the patients that are stuck in the ED. And we come up with a plan for every one of them. Some of them will be seen. Some of them will be evaluated for potential management in terms of medications. And we try to triage them as quickly as we can in 30 minutes or less. We're hoping to do that in Needham, and we're hoping to do that in Milton, but we have a resource issue. We don't have enough bodies at this point to do this. So just doing a deep dive into the Norwood Closure, you guys probably are familiar with that picture of the Norwood parking lot. I remember seeing that, I think it was on a Sunday, and I said to myself, that cannot be good. And true enough, I mean, the whole place had to be shut down. So as I mentioned above, this has dramatically impacted the emergency department because all the patients are now going directly to uh, Needham. I know that Riverside is trying their best to see them in the community, but it's a reflex on a lot of people's part, not just the patient, but also community providers to send them to the emergency department. And as such, we're seeing an increased number of substance use and chronically mentally ill at BI Needham. And the boarding times have increased dramatically, particularly since a lot of the patients that are being seen by primary care physicians in the area have Tufts Medicare replacement. And Norwood Hospital was the one that was capitated to take care of the Tufts Medicare replacement products. And with the closure of those 28 Jerry psych beds, it's incredibly difficult to find those patients' placements because no other facility will be allowed by Tufts to take care of those patients. On the inpatient side, on our med surge side, we have increased boarding. We have somebody on med surge who's been essentially boarding for the last 8 days. So it's been an absolute nightmare situation. And again, our med surg nurses are not particularly trained to deal with patients who are acting out. The other thing that's happening is non-emergent behavioral health and substance use are now going to BID Needham. So how can we address this situation? Well, one is, and Hillary had alluded to this, we can leverage existing clinical pathways. Plymouth was able to get another Health Policy Commission award to start medication-assisted treatment for patients with opioid use disorders in the ED. The order sets, the clinical pathways have been introduced to our Milton folks, and Milton was ready to start this in the ED, but the pandemic broke out. When I started working on this with Greg and Peter Smolowitz, the former chair of the ED at Needham, I was assured that there was no opioid use issue in Needham. I fear that that's going to be changing as well. I had initiated the phenobarbital protocol to take care of complex alcohol withdrawal syndromes in Plymouth. This is being used in Milton as well as Needham, but I have streamlined the process to allow patients to be quickly stabilized in an emergency department so they can be transitioned to med surg instead of having to go to critical care. And again, as you can imagine, in the setting of the new surge, this is a critical issue that we can't afford to have critical care beds taken up by people who are in delirium tremens. One of the advantages of BI Needham is that we have a terrific hospital service and an incredible medical director of the hospital service. Rania Elakiki has been working closely with me on many of our cases. And one of the clinical pathways that we're working on is a delirium order set to take care of our significant population of geriatric patients. One of the issues that we're working on in the task force that Hillary had alluded to in terms of addressing ED boarding is how to coordinate COVID-19 testing between the lab, the ED, and behavioral health. This is much too complex and so incredibly boring that I'm not going to waste any time on this, but this actually matters. Now, one way we can do this is a daily huddle in the ED. And unfortunately, we don't have troops on the ground in Needham, but I've been speaking with Greg about potentially utilizing existing infrastructure, albeit expanded infrastructure and maybe using a tele huddle um, within the 3 BI hospitals. I know that Nalin Ward at the system level is doing this at 11 o'clock every day, but this might help ramp up things in terms of figuring out the way to be more proactive in recognizing problems in the ED. Now, going to recovery navigators, these are um, people that used to have substance use issues that are now clean and sober, and they work out of Gosnold. They're working now in our EDs and med surge floors in Milton and Needham. I'm sorry, Milton and Plymouth, and they've been incredibly effective in working with patients with substance use issues who are reluctant to get care. So I'm hoping that potentially a virtual recovery navigator can be something that we can do at Needham. Now, PCO, Plymouth County Outreach, started out as 2 police chiefs with East Bridgewater and Plymouth working with a hospital. And what would happen is we would identify patients who are resuscitated in the setting of an opioid overdose. We offer them care for substance use. The ones that refuse are sent home. But since they're brought in by EMS, the police department has their names, and within 24 to 48 hours, they're visited by a plainclothes police officer and a social worker. Our success rate in getting those patients that initially refused care in the ED to get substance use care was as high as 86%. With the success of Plymouth County Outreach, we have now gone across the South Shore and Metro South, and we have 27 police departments. With the success of this, we applied for a grant through South Shore Health Systems, and we got a $950,000 grant to expand PCO into not just addressing substance use, but also patients with behavioral health issues. In other words, people who are identified as potentially at risk, not urgently at risk, but potentially at risk. And we're using the PCO model to reach out to them. Lastly, the drug courts. We have worked closely with the drug courts in Plymouth, along with the probation officers, and this has led to more therapeutic instead of punitive encounters. Now, in terms of expanding behavioral health interventions, I'd like to coach everything in terms of population health management. We have realized through our work with the Health Policy Commission that the most expensive, most difficult, most non-compliant patients, the ones that tend to go to the ED, the ones that tend to be readmitted, are people with psychosocial issues. And of those people with behavioral health and substance use disorder, are the ones that are most difficult to address. So this is essentially why I was delighted that Hillary and I were asked to join this behavioral design team as part of the pre-merger discussions in early 2018. And she had started talking about collaborative care. I started addressing the question of whether it's important to have a social work division in the hospital versus just nurse case management.
Hi, John's here, guys. Sorry, I'm a little late.
Hi, John. And I had started addressing the issue of leveraging and probably expanding existing infrastructure. Now, the role of the ESP, Hillary has, they own 3 ESPs up north, which is a tremendous advantage, but it's something that still needs to be addressed. And again, in the setting of the pandemic, the states and Mass Health's plan to take a fresh look at ESP intervention has been put on the back burner. Now, as an addiction psychiatrist, the holy grail in terms of addictions is finding a way to prevent the adolescent at the age of 13 or 14 from getting started. And I really meant what I said when I said holy grail. And I for years I struggled to find this, and the only program that is endorsed as evidence-based by SAMHSA is Preventure. And I'll talk about that after a couple of slides later. So the other thing that we have to start talking about is the school system interface, which I'll address with Preventure. And since John has come back, has joined us, he'll talk about the behavioral health navigator role.
Yeah, I'm sorry, I'm going to be short-lived. I apologize. I got jammed between two Zoom meetings, one of which I have to chair at 6, but I think we're intending to wrap up around 6 anyway.
Right.
Is that correct?
Yes. So I'll
Okay.
be quick, John, so you can jump in. But so I know that Sam and I had started talking about Preventure, and again, this is something that we can talk about some later point. But Preventure is in year 3 at the Plymouth School District, and we've had tremendous success already. That's another hour of discussion. But a quick slide about COVID-19 and mental health and the disproportionate share of young adults that it's affecting at this point. So why don't I stop there and have John chat.
Thank you, Danny. We have so much that we want to have you share, and I really appreciate everything you said. It was fascinating. I know John might want to say a few things, and then we wanted to leave a little bit of room. Alyssa has like a rock star team of folks from the community that I don't know, Alyssa, if there's a way of just even having folks just say their perspective, and however you want to play that, given that I knew we were going to have too little time to cover all these topics.
Yes.
Jo-
I'll let John start and then we can turn it over to the community partners.
Sure, I'll be brief. And again, sorry, Sam might have pointed out the meeting where we're having COVID surge meetings kind of every other day, given the circumstances in the state, and I got pulled into one at 5. So my apologies, and Danny, sorry I missed the majority of the lecture. But I think what I would say with regard to this topic at Needham, we've gone from a facility that had probably less than its average share of behavioral health to a site that has, I guess, as much as everyone else at this point, which seems like a lot to us. So we're building. As Danny mentioned, we're looking at different programs, and our team has done a pretty good job, I think, in reacting in a relatively short period of time. But there's much work in process. So 2 things I'd mention. One is with Danny's assistance. We are working to build our behavioral health provider staff at the hospital. We're working with Hillary and her team just to reach out to get a better sense of best practices within BILH. And then lastly, which I think has been announced, but the development of the Behavioral Health Navigator program, which we'll be doing through the courtesy of a very thoughtful and kind gift from the Trotman family, from Val Trotman and her family. That's an endowed position. We have crafted a position description for this. We've done that with some input from Hillary and her team and Danny and others. This will be an outwardly focused position at the hospital that will really be our point person in the community about making sure the appropriate information about resources in the community are out there, and of course directing people to the right resources in the community. So that arrival in the Needham emergency room is not necessarily the answer to every question or every issue. So we're very excited about it. It will definitely be a position that works very closely with our partners in the community, and we'll be excited to get rolling that out in early 2021. So I'll yield the floor to you, Alyssa, so you can introduce the folks who are doing the work.
Thank you, John. I'm glad you got to jump on. Alyssa, over to you.
Thank you. So our idea was to have some community partners join us today so that all of you can get an understanding of what is available. And if you know someone who needs resources in the community, that you're able to share those and know about them. So let's start with State Representative Denise Garlick, and I think she was going to just say a few words.
Hi, everyone. So I just wanted to say two things. I think, number one, thank you for this presentation. I am deeply moved by the fact that Beth Israel Deaconess Needham has done substantial work in the community. We're talking about the what that has to be done, but I just want to reflect on the why. We know through your work in the community assessment needs work that you did, that Needham has an issue around alcohol and substance use, around opioid use. I was surprised when Dr. Mendoza said that someone had told him that that wasn't our issue. It's been our issue for several years. And our increased support for older adults, as well as for our youth mental health and substance use. You've clearly identified those needs, and that is what's driving the need for you to find the what and how we can serve the people. And I would just say that for all of us, it's a multi-legged stool. Certainly the community, not only our youth services, our council on aging, our public health department, but the ability of the hospital to meet the community where it's needed, and the state's responsibility around resources, around the budget, DMH, DPH, and connecting people to discuss these issues. So I've learned a lot tonight. I look forward to our work together.
Thank you so much. We have Sarah Burrar from Westwood Youth and Family Services. Sarah, are you still? My screen keeps changing. Oh, there you are. Okay.
Hi, thanks for having me. This is wonderful. Nice to see everybody. So we are a department in Westwood, similar to the same department in Needham, serving the youth and family in Westwood exclusively, free counseling, free mental health services, confidential. We also do preventative programming. So very much available for all Westwood residents. We can just be a point of starting if people need more support in Westwood and they don't know where to go. So it's nice for us also to know what else is out there. The trend that we're seeing is certainly an increase in referrals. This is a busy time of year always, but increase for outpatient counseling referrals. And the number one presenting issue is anxiety. So folks that were already struggling with that, I think it's been amplified by the pandemic. So we're doing what we can, and we appreciate seeing the community. Thanks.
Thank you. And we'll stay with Youth and Family Services. We have Sarah Shine from Needham.
Hi, everyone. Thanks for having me. Very similar to Sarah's, we have the same division in Needham. We work with youth and family. During this pandemic, we have also opened up our services to really anyone in need. So anybody that has any kind of mental health need, they don't know where to go, feel free to call us. We're happy to guide you in the right direction. We've also seen a significant increase in the need for services. We work very closely with community partners. We've gotten together in an alliance of people to get together to really support those community needs and can connect people for various services that they might need through this difficult time. We've also created a resource page that is on the public health website. If people need other kinds of resources, you can check it out. Let me know if you have questions. And also we are offering a wide range of preventative services as well. And thank you.
Thank you. And then we have Karen Shannon. Karen runs the Substance Prevention Alliance of Needham.
Good evening, everyone. Thank you for having me. As Alyssa introduced, I'm Karen Shannon. I work in the Needham Public Health Division, along with my colleague Carol Reed, who is here today too. Both of us work in youth substance use prevention, and in particular, I oversee the Substance Prevention Alliance of Needham, which is a community coalition whose mission it is to help reduce and prevent the use of substances by our youth in Needham. We bring together a lot of different stakeholders in the community, and in fact, Alyssa has been a very strong presence on our coalition for a number of years. leading our parent action team. But our role, as we see, is really to establish relationships in the community with different partners so that we can put together strong programs for prevention for our youth. Thank you for having me.
Thank you. Carol, did you want to continue?
Sure. Hi, I'm Carol Reed. I work for Tim McDonald in the Needham Public Health Department for 12 years. I currently am funded by a state substance abuse prevention collaborative grant. I work primarily to prevent underage alcohol use with the public health directors of Needham, Dedham, Westwood, and Norwood. And I also told Alyssa to not be redundant with Sarah and Karen. I'm on the Medfield Board of Health. I've lived in Medfield for almost 29 years. And I just want to say that Medfield also has a very active youth and family services division with a new director, Kathy McDonald, and a full-time social worker. And I know that Medfield is a part of the BID Needham system. And Medfield also recently, for the third time, applied for a federal grant, the SAMHSA Drug-Free Communities Grant. So they now have hired a full-time prevention person to work to get the community together through a coalition model. Lastly, I'll say Medfield also has, thanks to Denise, an active suicide prevention coalition that in response to loss in our community during the past 2 years, varied stakeholders get together and are working to increase awareness and access to resources to support our youth. What we know also, how grateful we are in Medfield, is the intersection of substance use for our youth with mental health. So we feel like now Medfield is in a really great position to support our young people. I also want to say one last thing. I worked in addictions at NORCAP. I don't do that work anymore. But when people call me, I encourage them now with COVID. Mass 211 has a 24-hour support line, and you can press 26. Sometimes people are worried at night about their children, their elders. So I encourage people, Mass 211 from any landline or cell phone, and then press 26. And Governor Baker has set up support people to answer myriad questions about COVID. And it's really been untenable and the stress is difficult. So I always say, in addition to the social workers that are at Riverside 24/7, specifically on COVID, you can do Mass 211. And thank you for letting me talk. I really appreciate all the work Alyssa has done to bring us all together consistently, and John and Sam. So thank you.
Thank you. I know we're getting close to where we said we would end. We have 2 more people who I would love for you to meet real quick. The first is Jessica Moss. We've talked about youth, and Jessica's kind of at the other end of the spectrum.
Thanks, Alyssa, and thank you for including me in this presentation. I'll be brief. So I'm at the Needham Council on Aging, and we have a team of social workers that provide free case management services. We help with public benefits, applications, all sorts of things. We also recently launched a COVID-19 telehealth therapy program. So 8 free weeks of therapy via phone or Zoom, kind of whatever is accessible to older adults in Needham. We're seeing also, what everyone else is saying, a huge uptick in anxiety. Social isolation with our population is our biggest concern. And so the other program I just wanted to briefly mention that I'm really excited about is our Tablets and Tutors program. So in partnership with the Needham Community Council, we've already given out 30 free Amazon Fire tablets to older adults in Needham, and more are coming. And with those tablets, we're offering free tech support to seniors. So we had a 94-year-old who'd never used a computer, smartphone, anything before, and she was emailing me emojis. So we're really excited about that. So please feel free to send, any referrals, anyone you're concerned about, our way. And thank you again.
Thank you, Jessica. And last but certainly not least, we have one of our biggest partners in the area of mental health, Riverside. So I will introduce Satya Montgomery from Riverside.
Hi, everyone. Thank you for having me here. I'll be really quick since we're at the tail end here. So Riverside has a range of services from early intervention all the way into the elderly. And we have outpatient centers, 5 of them, and we're pretty much providing services there through telehealth, about 99% telehealth. We do have people coming in if they need to. But we also have a new program we launched in March, which is recovery coaches and recovery support navigators. And all of those services are being done via telehealth as well. So that's something that people can access fairly quickly. We also we have a trauma center, which someone talked about, the Mass 211 line. So we are providing support as well for those who are struggling with anxiety around COVID. That is 24/7, and we do have a response team to assist. And we also have our trauma center can also provide more in-depth responses to that as well. So thank you.
Thank you. I did want to mention, and we can send a follow-up email with more information just so as not to take time today, but we do support the Interface program. Interface is a mental health hotline where you can call and get a referral for a mental health provider. So I will send information about that. We'll send a follow-up email to this and include some information on that so that everyone can have that at the ready in case you need it. And I'll turn it back to Sam Berman.
Thank you so much, Alyssa, and for all the members that spoke. And Satya, thank you for all the work at Riverside. I've been a utilizer of your emergency services, and I really appreciate you being there. This has been such a rich conversation. I knew it was going to be, and it exceeded my expectations. So I think given the time, I'd ask that anybody who has questions or comments, please email those back to the invitation. Alyssa, it will go to Alyssa, and then we can get those answered and reach out as need be. And just our next in the speaker series is going to be by one of our primary care physicians with regard to self-care and physical health especially after the holidays or around the holidays. But we'll also, I'm sure, be reconvening this type of group to talk more about behavioral health and some of the things that we're doing. But I want to very much appreciate everybody who participated and hope you all have a very good, safe evening.